Good morning, everyone. My name is Michael Rambo, and I'm the Medical Director in Integrity. This is a program that is quite important right now, the use of naloxone, with opioid use. This slide pretty much gives a very, very serious message. People who are using drugs may invariably have some degree of opioid interaction. They may have contaminated or directly use it, or they're just asleep, they will wake up. This is what may happen. That person may never wake up. This has become so serious with so much heroin all over the country that right now many states, we're a little bit late, but still quite in the first 10 states doing this in the union. Getting Narcan available, having people use it. Narcan and naloxone has been using medicine for a long time. They realize that this could save lives by using it and having members of the public be trained, lay folks being able to use it, changing laws such that people don't have any culpability with law enforcement and people feel free to help if they see someone who they know has an overdose of drugs, which statistically has a high likelihood of also being involved with opioids. Okay? So the first thing is, we'll go through the objectives that we will have with this program. We will understand very briefly the current drug epidemic. We will look at signs and symptoms. We have some very nice slides to show what these physical findings are. The New Jersey law that an existing signed in May 2013 in terms of protecting members of the public. You don't have to be a healthcare provider. If you see someone you can help, you can call police, they will come by and help. You will not be held accountable. The idea is you don't turn away and leave someone who could potentially have been saved, but they will allow it to just die. Okay? We'll also look at how we prepare that. This is the stuff that we have there. And how you basically administer the responses that you expect. Okay, it's quite simple, but it's very practical and time is of the essence, knowing what you have to do. These things also come available as kits. A Narcan kit that actually has this atomizer that you will be seeing a little bit later. Everything is all self-explanatory in 3 or 4 steps. What you do, how you actually give it, how long you wait, what's the response you're expecting. So it's quite user-friendly. As more people start using it, you will be more familiar with this. Okay, so basically, the trend has increased. This upper line here, you're looking at significantly opioids, and this has actually reached up here right now, the most recent data, for which I didn't have a slide. But simply, we have a huge drug problem. Some of the other drugs are quite constant, but opioids is quite big. And a big problem is not just heroin, but prescription drugs. You guys are familiar with that, right? Well, there's a law in New Jersey where physicians have to report. Initially, until I think it was March of this year, they had 14 days to report if you give a prescription for a controlled substance. That got changed recently. It has to be within 24 hours. You have to report if somebody got a prescription. So let's assume this gentleman got a prescription last week under old law. He was still overdosed on something, and if the pharmacy that he went to takes the 13th day, this public law, to report it, I wouldn't know what he got. The law has been changed. It's now within 24 hours, so if you got something 2 days ago, you come to see me, oops, it's right there. I know exactly what he got, how much he got, who gave it to him, which pharmacy filled it, how he paid for it, and the time it was dispensed. It's all law. All doctors by law have to go on that site, ngrhport.com. We all can give them a specific password and we have to sign up. It's a very, very secure system. It's all about doctor shopping, opioid use, and drug interaction. Huge problem. Okay? Basically, within the US, you can see the different states, the problems that we have. So a place like Texas would be less than 5. This is not the most recent data. Every state has had at least a 10 or 15% increase. The Northeast and the West Coast, quite significant with opioids. The Midwest is significant use of solvents and stuff from the garage. So what you find is based epidemiologically on what is available where. I spoke to a colleague from Australia 2 weeks back and said, oh, cocaine is not heard of there. Amphetamines is big across there. Somehow cocaine has been kept down until now. So different parts of the world, different drugs available. Pretty much it's the substance use problem. Okay. So, in terms of the overdose from opioids, okay, naloxone, also called Narcan, is the antidote. We've been using this for over 30 or 40 years in medicine. It is used in intensive care in an inpatient setting. It's highly effective. You cannot abuse this drug, okay? If you do not have an opioid problem and you basically get it, nothing happens. If you have an opioid problem and you get naloxone, you're going to withdraw because it's an opioid antagonist. It opposes the effect of opioids, okay? And basically, the effect is within minutes, right away you basically see. Why do you want to do this? Opioids work in a part of the brain called the brainstem, and it affects your respiration. And you slowly stop breathing. You appear like the second slide to be the young lady who was asleep. Leave her alone, she will sleep it off. No, she doesn't. You remain asleep permanently, you die. Okay? So this is a very, very useful drug, and right now you realize the same liquid that you will be using in the intensive care or in an inpatient setting or in the emergency room could also be used in an outpatient setting or on the street. People also have this at home. Many doctors are giving prescriptions to family members who can get this filled with a small kit if they know that a family member at home has had in the past a substance use problem. The idea is that person may be at high risk. Before you call 911, time is of the essence. You can give this, keep the person alive, breathing, until paramedics arrive, but you first have to have it at home and of course be familiar with how you use it. Okay? So, why are people dying? You don't know the signs and symptoms. The person's asleep, leave them alone, they will sleep it off. You know, this works on the brainstem and it just stops your respiratory drive. So you stop breathing, you die. Okay? Not knowing what to do, the stigma with drug use, and also the fear of police. So, the stigma of drug use is still there, but it's slowly decreasing. We're accepting as a society that substance abuse, drug addiction, is a chronic brain disease. It's just like high blood pressure, diabetes, arthritis, cholesterol, and it also has a very similar natural history in terms of what happens when you're treated, your response, degree of compliance, and your long-term prognosis. However, substance abuse is still a very stigmatized problem in society, but that is slowly changing. Okay? And of course, with police involvement, like I said, since May 2013, Governor Christie is, I think, about the fourth or fifth in the union who signed such laws into place where people are protected. I believe it was 2 years back, was either in New Hampshire or Vermont. The governor, in his state of the state address, devoted the entire time speaking about substance abuse because it came very close to home with a family member who I believe passed away. See, so it's going to affect anyone. Okay? And when politicians buy into it, the likelihood of this thing really staying on the forefront is much more likely. So, who is using prescription drugs? Basically anyone. Could be elderly, college students, young people, chronic pain, street drug users. We get to stigmatize and look at people on the street and have a specific stereotype, but anyone could be using drugs. In the medical field, who are the biggest abusers of drugs in an illegal sense? Doctors and nurses. Why? Because we have access to it. Okay? We have license which allow us. That's why no one is immune from this. It's not the guy on the street who looks suspiciously over his shoulder. You cannot stereotype this. It could be elderly folks. We've seen some people here at Integrity, upstairs in the medical department, who came for treatment after going through the legal system, and people in their early 60s. I actually spoke to one and told them, when did you start using drugs? You know, when I worked, I was fine all my life, retired 3 years ago, went into a housing complex, ended up with the wrong company. At the age 60, it can happen to anyone at any time. Okay? So there is no specific stereotype or fixed profile for a person with substance abuse. Okay? the signs of opioid poisoning. The first and most common one we look for clinically is what you call pinpoint pupils. The pupils become very, very tiny and round. They almost look like the tip of a pin, the head of a pin. That's why it's called pinpoint pupils. Okay? You also will look at the breathing starts to become shallow. And this is where if a person has had opioid overdose and you leave them alone, they're initially breathing, then they slowly start decreasing their respiratory rate until they eventually stop. The idea is intervene. Okay? That's why the second slide, leave her alone, she'll sleep it off, is very deceptive. She will not sleep it off, she will not wake up, period. Okay? Also, your fingernails will get grayish or blue. This is because you become cyanotic. When you decrease your respiratory rate, you can't exchange as much air, and with it oxygen, which your whole body gets. When your fingernails get bluish or grayish, this is called acrocyanosis because it's the tip of your fingers. When your tongue gets cyanotic, it's called central cyanosis. The first area to get cyanotic, when you start slowly going downhill, is your fingers, your nail beds. Okay? And the second area is your tongue much later. You also don't respond to stimuli. Okay? Because your whole brain function is suppressed. So when it's waking you up, you're difficult to arouse. And of course, at some point, you will start with wheezing or gurgling because of fluid in your lungs. Okay? You don't have to wait, this is, quite advanced. Pinpoint pupils, altered mental state, high risk. It's safe enough to use it. And of course, we'll have a question and answer session about those things, when, who, how, and why. So, physicians, based on this law, could prescribe this to anyone to use. Okay? Or if someone has a family member, I know of 2 or 3 such cases where family members have prescriptions. I have given just one so far where I was requested by a colleague who wasn't quite familiar with addiction. But there are many physicians involved in addiction doing this, where they give a script for the family members to go to CVS, Rite Aid, Walgreens, and get that little Narcan kit. You could even go on the internet, on YouTube, and you can see a little in-service, at least a dozen of them, how you actually use it. So you know if something happens, or a family member at home who has a history of substance abuse and is at high risk, if this should happen, you call 911, but you immediately give this. Okay, you will save the person's life. Okay? And also immunity to the prescriber. Doctors, again, like I said, this is a drug that you cannot abuse. Narcan is an antagonist. The agonists, or the partial agonist antagonists, have the potential for abuse. An antagonist cannot be somebody who has a substance abuse problem with opioids and should take an antagonist. You feel horrible, you go into withdrawal. You know this is something you don't want to use again. So the abuse potential for naloxone is nil. Okay? That's why it's so safe. In the best case scenario, it can help someone, it can stimulate the brainstem, kickstart your breathing again until the paramedics arrive. In a worst case scenario, you squirt some liquid into someone's nose and nothing happens. So you have all to gain, you have nothing to lose. It couldn't get simpler than that. Alright? There's also grants available in different states and different places. I did a program in October last year with some follow-up in Essex County where there were some grants from the prosecutor's office with funds, I guess, with seizing illegal stuff and so that they used to purchase those kits, and they give to all the municipalities where the cops were trained. I actually trained them and they were using it. And there have been at least a dozen or more rescues in Essex County since October of last year using this program. It's up to them if they want to continue it. I think that they will. So first, you start with caring for the person. Make sure that the person, hi, how are you? Are you okay? You realize the person is not responsive. You call 911 and then you start giving this medication if you have it right there. Okay? So naloxone is an opioid antagonist. It opposes the effect of opioids. So if an opioid makes you drowsy, decreases your breathing, decreases your blood pressure, naloxone will do the opposite. stimulate you, make you awake, increase your respiration, okay, and will also not decrease but cause your blood pressure to remain stable or to increase, okay. It still must be prescribed. A doctor has to give it. It is not scheduled, it's not controlled, and it's not abusable because it's an antagonist, okay. People who use drugs will never use this. This has all the opposite effects compared to what we expect, the feeling of a high and good and dopamine and so when we use drugs, okay? No effects on this opioids are present. Like I said, if you don't have opioids in your system, nothing is going to happen. If you have opioids, you get better. So in a worst case scenario, nothing happens. If you use a drug, it's an overdose, but it's not an opioid, nothing will happen. Best case scenario, it was an opioid and the person will be revived. Okay? That's very important. So, and this is used by EMS, this has been around for a long time. They've been using this, but it's now being available to the public at large. You see someone at home, you try calling 911, maybe take 5 minutes. Who knows? It took you 10 or 15 more minutes before you saw that person, and then you call again. It just requires 4 or 5 minutes before, because of hypoxia and lack of oxygen, you get permanent brain damage. If not, you die. So having it readily available, you should be fine, okay? Lay people can actually give it with training, and that's the whole idea behind these Narcan programs all over the country. Just was started in the Northeast, I think it was in Massachusetts or Maine. It has been spreading everywhere. Okay, so why intranasal naloxone? Very low risk. The idea of giving naloxone until this became popular was it was always given with a needle in a vein, and it involves certain health risks. A healthcare provider using a needle stick, hepatitis, HIV, what else a person may have. So that would put the lay public at risk unless you're a trained person in an emergency room, a paramedic, or you're working in an intensive care. By making that same drug available with an atomizer, you guys go to CVS and buy one of those, and there's a mist spray, and you squirt it, prints a little paper. It's the identical principle. Okay, so there is no needles. There is no risk of getting stuck by something, which definitely would be a risk that many law enforcement people initially had reservations about. And that's why some of them were not doing this. Some were also trained as paramedics, and when they worked as paramedics, they willingly did it when they're working as a paramedic. But in law enforcement, they stayed away, and quite rightfully, people maybe get accidents may happen, and if you have needles, guess what? The risk of a needle stick goes up. If you have lay folks, it's even higher. So this has no potential for anyone being stuck. There are no needles, okay? You can give it very quickly, a little training as we'll see shortly. It has a fast onset of action, 1 or 2 minutes. It's very effective, and you can repeat it if the person becomes awake. A person who has an opioid problem and gets this, when you go into withdrawal, some people that you'll see later can react in a very violent and very physical way. So if you're doing this kind of stuff, some basic precautions you have to take as we'll see later. They're in the place around, no sharp objects. The person is that swinging it, the arms and legs all over. You take some very basic common sense precautions. The idea is you're trying to help someone. Because, well, if this person could pick himself up and get injured, you're doing this because you want to try and help someone. Not because if you don't want to do this, you could find 1,000 reasons why you shouldn't do this. End of story, we don't need to have any more discussion. If your desire is to help people and you really want to be a part of this, you do this for one reason. You can potentially save someone. That's why you're doing this. There'll be some little risks and so. Alright? So, basically, the person is lying. I will, I demonstrate this shortly. You shake the person, hello, are you awake? Hi, are you alright? You realize that this person is, very much in deep sleep. Hopefully, at least at that point, has some shallow breathing. You may or may not get a pulse. You may or may not see pinpoint pupils. The fingers looking grayish or bluish in color, as we mentioned, after cyanosis. And that's when you will basically, with the person lying flat, with that little device we'll see shortly, you basically draw up the liquid, the naloxone, in this little atomizer, and you squirt it. It comes out as a mist, okay? And in the back of the nose there, at least a couple of you have at some point had a nosebleed, either with dry heat or nose picking or what have you. At the back of the nose, it's a very vascular area with a lot of blood vessels. It was discovered by a guy many, many years back, and it's named after him, called the Kieselback plexus. It's a very, very vascular area, and when you spray this mist, it comes right around there. That's how you basically give it. And as it gets into that area there, it's directly absorbed into the bloodstream. When this is directly absorbed into the bloodstream, it immediately has its effect all over. Okay? You give a drug intravenously, you get the effect right away. If you give a drug intramuscular, it takes a little bit longer. If you give it by mouth, it takes the longest. And the reason why these things are different is because it all depends on how fast the drug gets into your bloodstream. So if you give it through a vein, it's directly into your bloodstream. You get the effect right away. When you give it intramuscular, it takes a bit longer for the muscles to be absorbed into a blood vessel and then starts the exerting its effects. If you take it by mouth, it has to go into your stomach, broken down, go into your intestine, and then be absorbed. That's why if you take it by mouth, it takes a bit longer on a comparative basis. Intramuscular, a little bit shorter. And if you give it intravenously, the shortest is all about how fast the drug gets into your bloodstream. By doing this simple maneuver there, no needles or so, you go to a part of the body that has a lot of blood vessels, and this medication goes directly and is absorbed onto the blood vessels into your bloodstream, and that's why you get the effect right away. No needles, no one is at any risk, a very simple maneuver to perform. Someone just lying flat. Okay? Now, this is how this device here looks. This is your normal standard syringe, a 3cc syringe. Okay? This is the little patented device. Somebody was pretty savvy and got a patent on this. And this is selling like hot bread. You can't get enough of this all over. So that person makes a penny or maybe a nickel. Oh, it's a wealthy guy. He's somewhere in Florida. He's enjoying it. Because these things are going off the shelf and it's not being used for lots of different medications. What this does is you attach it onto a syringe that we would normally do if you're going to draw an IV or so. You have the liquid in here, which we could use any liquid for demonstration purposes, and you push up and it squirts. It creates a mist, and it's that mist is what is absorbed at the back. I'll give you a little illustration of how that goes. Are we clear away? Are we all set there? Yes. Just keep looking at the top there. What's going to happen? Sorry? That's the mist. Same effect there. This is what goes at the back. And when you basically make it into a mist, it disperses more evenly. It's more easily absorbed onto the vessel, goes directly into the bloodstream, where it exerts its effect within 1 to 2 minutes on the brainstem, the area that controls breathing. Okay? So, what does an overdose look like? Someone is there, you see someone, they're not responsive when you shake them, they appear to be in deep sleep, they might not be breathing, or they could have very shallow breathing. Okay? If someone is not breathing and you arrive soon after, you can still initiate breathing, okay, and resuscitate that person. Okay, they could be snoring deeply or gurgling because of extra liquid from the lungs and in the mouth. The bluish skin color, the lips, and again the pinpoint pupils. The same things we looked at earlier. These are some of the most common presenting features you can see in a human being in front of you who has an opioid overdose. So, if the person is not responding, that's an indication to use it. Remember, a person who's not responding, you can say, oh hi, when last did you use heroin? That's not going to happen. This person is in deep sleep. This person could probably be, in the next 10 or 15 minutes, be dead. So you don't know. This person is unresponsive, but is in a high risk situation. You might see the drug paraphernalia around. You might see a history of having substance abuse, you have some risk factors that tell you that this person is high risk. So this person is not responding, this person cannot tell you anything. You have to make a clinical judgment based on your own common sense reasoning and what you observe and what you see right there. Okay? Bystanders might say that this person has a history of drug use. The person might not be responding. Or you might see signs of track marks and stuff. So whatever it actually is, it's high risk. If unsure about the risks, remember what I said. You cannot abuse this and there is no downside to this. You give it. Okay? Worst case scenario, the person was using something else, not an opioid, nothing will happen. Best case scenario, in the combination of whatever that person may have been using, opioids were also present, in which case the person will kickstart their breathing, remain alive, while 911 hopefully arrives here within a few minutes and then takes over with more invasive care, takes them to the hospital for further evaluation. Okay? So, this atomizer you actually saw now, it comes as two dosages, 1 milligram and 2 milligram. These are little tiny tubes. It's the same medication we've been using, but it's now available as little tiny ampules, especially designed to be used with this. Okay? And it comes as a syringe that looks just like this, but a 1 milligram per cc, and in some cases 2 milligram per cc. The little tiny contraption is a little package that contains everything called a Narcan kit. We'll have this in there as well as this little device kit. What you will do, you will basically do is dismantle the whole thing there, and it has very simple instructions with some little pictures. All of it is quite standard how you actually do it, but practically doing it makes you a bit more comfortable, so when you in real life have to do it, you have some sense of what you're actually doing. EMS will take it to a higher level again. You're just trying to keep this person alive, okay? And again, poison control center would be something a little bit later. The idea is just keeping this is like giving complete care. That will happen a bit later. So, this is an actual picture of the devices that comes in that Narcan packet. You have this atomizer that we just saw here, which is this little white mushroom-shaped device. This is a syringe just for illustration purposes, which is what the vial of naloxone will be. So this vial will have this device there, will be attached up there, and then you squeeze. Okay? And this whole device, this comes fitted in that. This would be there, and then that would go at the top, and then you basically squeeze it. What I'm doing is using a substitute where this syringe is equivalent to this with a Narcan and this whole device, and you just attach it there with this medication in. So for practical purposes, this is what he will have. This is pretty much, this and this is what I am substituting here, the identical technique. This is that. You basically do this, and it's all set to use as you saw a few minutes ago, where that nice stream comes up. This is the steps which we have gone through. You basically put the syringe into this cartridge, you attach it, you remove the cap from the vial. We're not going to use an actual Narcan kit for illustration purposes because beside having a cost factor, it's something that could be used, in a live human being if you need it. And I have actually tested this, used it several times. It's the identical principle. I can just feed some faucet water, and that's fine. It's the identical principle. And Narcan is a liquid, same viscosity and density, just like water. So this is why you see the same mist principles. Everything is identical. Okay? Then you attach that little atomizer at the top, and then you spool it. And this is how it's ready for use. Just the way this would look. All right? And now, so you firmly shake the person, this person is lying flat. You may gently turn the person to one side, and you give us one of those. What you basically do is you will have probably 2 cc's in this. You turn the person to one side, you place it in, the person is lying flat, and you squirt in 1 cc. You wait 1 minute. Again, this goes directly to the bloodstream from that area called the keystone plexus. We spoke a few minutes back. And it takes about 1 minute for you to start seeing a response. If you need a little bit longer, but you're looking at the person right there. The person may have very shallow breathing, but the person should start picking up. If the person does not, then you could spray the other half. You could try to go on the opposite side, or if for any reason, when the person is positioned or what's happening there acutely, you could not move the person to get the opposite side, then you put it on the same nostril again. Okay? So you'll give both doses on the same side. If you couldn't give half on one side, then the person give half on the other side. This person lying flat on the ground. Okay? What happens next? This will antagonize, it's an antagonist, the effect of the opioids in your brainstem. The person will start breathing on their own. It really kickstarts your brainstem, which controls breathing. And the person will then start going into opioid withdrawal. Sweating, sneezing, confused, they get angry, may even get physical. That's why I said before you actually do this, knowing what withdrawal looks like, the person could get physical, not because they want to beat anyone up, but that's just the expected clinical response when we go into withdrawal. Okay? So you remove sharp objects, stuff, and if there are any observers, hopefully there's not too many observers, people should be happy with us if we stay away. Have a nice play area around so the person starts to wake up and starts to kick or prance or have physical movements. No one's will get hit or struck, there's no sharp objects that cause injury to that person or anyone else. Okay? And again, agitation. It's a pretty agitated guy. Some people can really get quite violent in their physical expression when they go into withdrawal. Okay, and I think many of us should be quite familiar with that. So you just want to be cautious and careful about it. You can get the goosebumps, yawning, you can get nasal secretions, their blood pressure could go high or low. Okay? The fear of causing withdrawal should never prevent the use of Narcan in somebody who's unresponsive. Again, there are many reasons why you may not want to do this or be involved in it. We're here to teach, share information, and to be part of a process. There are many reasons why an individual could decide on their own, and that's your right. The ethics is a whole different discussion, why you don't want to be involved. When needles were involved, this was a big issue for many, many years, until one savvy guy came up with this little thing there. So you remove anyone getting stuck or so. If there's drug paraphernalia around and stuff, you just move those things aside so you can get stuck. What you are doing and your intervention is completely risk-free. The laws of these in Jersey, and it's happening through the whole country, now will completely protect you. We could even put physicians who have patients that report a family member has a drug problem. That physician can write a script, completely traceable, nothing illegal, it's a non-controlled substance abuse, so it's not scheduled, without seeing that person here. Okay? You're not going to keep it at home, hopefully your family member gets the help. Okay? So we've gone from one extreme to the other. We have learned quite a bit, and the idea is to try and help people. So remember, we make one big assumption while we're all here. We want to try and help. Okay? Sometimes things happen. But you do it with your best of intentions. Okay? Now, the safety consideration in short acting could be as brief as 30 minutes, sometimes much less. You can give it once. You obviously call 911. You may have to give this a second or a third time based on how long it takes for the 911 paramedics to arrive. You have the supplies there, you repeat the same technique again. And again, you'll be observing this person there first. They may be a little bit physical, and then slowly they're talking to you in a few minutes, just slowly start becoming somnolent again. It's because it was only a temporary effect of antagonizing the opioids at your brainstem. So you give a second dose. the person wakes up again. You may have a little 5 or 10 minutes buying time, during which time, hopefully, paramedics will arrive. So you can repeat this as long as you need to keep this person going until the highest specialized level of help arrives, namely the paramedics, EMS. All right? All patients who actually get this, you check for the altered mental state. Breathing is a big one. Okay? And once they're lying flat, circulatory compromise should not be a problem. You're not going to be sitting this person. This person will remain lying flat until paramedics arrive. Because when you have opioids in your system, it will cause a decrease in blood pressure. So if you pick this person, put it in a chair, and suddenly, because under gravity, okay? So the idea is you lie flat, so that blood evenly distributes throughout, and at least your brain, most importantly, your brain will get perfused. That's what you want. If you get cold hands and feet, nobody really cares too much. As long as your brain is perfused until you get the right help, you will come out of this without any permanent sequelae. Okay? Second, a third dose, based on how long it takes for the paramedics to arrive. Alright? Adverse effects in chronic opioid users could place bystanders at risk. And again, this is more about the physical aggression. People who have chronic use may have some degree of tolerance, as we know. You may have to give a bit more, and when they do react, yes, they start breathing, but the physical outburst could be quite dramatic. Again, you take the right precautions, stay a safe enough distance. This person is right there, you are at the side, you basically give it properly, and if you just stand back so the person starts to, fists start flying, and so the likelihood of you being struck will be minimal. Okay? And bystand is a safe distance. Very important. You don't want to have people get involved in this, unnecessary lawsuits. People who are directly involved right there, everybody else move out or hopefully stay away. So, in summary, hopefully we've learned about how bad this epidemic is. Intranasal and naloxone, we also learned about the laws, where people can help now very freely. And if a cop comes by now in New Jersey with somebody who had drug overdose, where 911 was calling, you trying to just get up, or even without any Narcan, just shaking the pulse, just trying to just, keep them going, stimulating them. Law enforcement will take over, hopefully paramedics are close by. You're not going to be held liable for anything. Okay? Okay, you stay right there. Put your hand behind your back. You are going in. What are you using? They might even see evidence of drug use. The law has changed. The emphasis is no longer about cut you at the same time. Cheats with a bit more. No. You're trying to save him. Let's try and save him and hopefully get both of you into treatment, as opposed to, you were using it, you're going to make it, but I also got it. This is the traditional way how law enforcement looked at it. That's no longer the case. Okay? And there's a law to protect people with that now. Like a good Samaritan type law. Alright? We learn also how to use the intranasal naloxone, how to prepare it. And what I want each of you to do is you can just come up here and get a feel for this. If you want to even, what I basically do is at least give you a feel how you basically use this. And you can even, if you want to screw it down or up, try to put basically, not wet too much area. Obviously, you'll get a feel for it. First, I'm going to basically take it off and put it back on. Screw it back on there, and then screw it a little bit. It's a very simple device, but it requires a bit of, hands-on. Okay, so that is, there you go. First, we take it off. We will screw it on. You pull it up in. That's all. Next. There you go. Any questions for me?
How much do you put in it in order to, how much go in there? A certain amount?
This will have 2 cc's. This will come as a pre-assembled contraption that has 2 cc's in it. And what you will do after you basically put this in there, you will squirt 1 cc. You're looking at the max, you squirt 1 cc into one nostril, you wait a minute or two, and then you, on the opposite side, the second cc. If you conduct it on the second side, on the same side, you squirt the second loop. Okay. Very fine. Who's next? Come on, Mike. No questions? One question, please.
Okay.
Have any of you used this before? Has anyone tried using naloxone in an acute situation where the kit was available? No one? Given what we do at Integrity, there's a very, very high statistical likelihood that we will be using that. There was someone, Nora and I spoke a couple days back, who was admitted in Newark and had similar problems with overdose and had to be resuscitated. So this is what we do here. We are not part of the public where you might and you hope you would. We are more than likely. There's a greater than 50 to 75% chance because we are an addiction treatment facility. Okay? So we all need to be familiar with this. And as many of us can learn and be familiar with this, the better off we will be, the more equipped we will be to try and help people and to save people. Okay? And I've known one or two people who actually had problems like this and got help and things turned around. You just never know. So if there's something that we could actually do, we now have the medication, we have a user-friendly kit, we have a legal system that has changed in favor of helping people that got you put in jail. And we now have in-servicing, and there's also funding and grants available for this treatment. There's probably something more to it. We should really embrace this and see what we can do.
Is there ever a chance that like the 2 cc's won't bring somebody out of it? You do the first one, and then...
Yes, there is a possibility. Well, let me redefine. Said, is there any possibility that the initial 2 cc's will not bring somebody out? You will see some initial response. It may not be an optimal response where the person completely starts to breathe on their own or even starts fighting, but it just tells you that more than likely means you're dealing with somebody who has a chronic problem with high tolerance. So you need to give a second set. But at least you will see some minimal response. Not the complete optimal response you would like, but there will be some response, which means you just need to give more. That person has tolerance. And again, while this is all happening, 911 was called, so you're just going to keep this person alive, breathing until the paramedics arrive.
Another thing that I've seen before is that the person is angry that you gave them this medication.
Oh yes.
Because they feel like you're messing up their high.
Right.
And you're putting them in withdrawal. So
Yes.
they might curse you out.
They're going to curse you and
You know.
start kicking and all of those things. Besides the physical act of withdrawal, forget they being angry just makes it worse. It could be quite something. This is why I said this is not a drug that will be abused. This is an antagonist. All the effects that opioid give you make you feel good, and the dopamine and everything else, and in the process probably also even kill you. This does the opposite of that. So this is why this drug is not scheduled, okay? It's not controlled, and it's a drug that will not be abused by people who have a substance use disorder. It does not give you the effect that you expect with dopamine release. And yes, some people can get quite angry and quite nasty about it. That, we'll deal with, that's more about style. The substances, at least, they remain breathing, they were alive. Then they were happy, contented, and stopped breathing, and that's it. I think as a society, we look at several human beings a bit differently. They can be angry after, at least staying away, so when they start prancing and hitting or kicking and stuff, and some people have seen one or two quite dramatic cases of withdrawal, you don't get physically injured. The big seller with this is a little tiny device that you can go to CVS or little kids can play with. there is no risk for anyone with this. Unlike when it had to be given as a needle, even intramuscular or whatever. Healthcare providers, law enforcement, or it's a non-controlled situation, people can get stuck, needles, HIV, hepatitis C, those things have all been taken care of. And it's the same medication we are using now, we're just atomizing it as a spray. See, it's the same medication. So there is no risk to anyone. And needless to say, the price has started to go up a little bit, which I find to be very less than acceptable. It was fine and available, and probably almost buy one get one free. Now it's pretty much in high demand, and the companies have increased the price of it. But I think with time that will have to go down across the Canadian border. If you go on the internet and you see these things available at a fraction of the price.
I wanted to point out in Secaucus, anyone that works in Secaucus, the Narcan kits are on the first floor, like in the halfway house hallway, in a box that's labeled Narcan. There's a zip tie that you would need to cut off with scissors. I need to put a weaker zip tie, and I think there are 2 kits, and I think each kit might have 2 vials that are each 2 cc's. And there are instructions in the kits. In Newark, a little more complicated. I gave Tom a kit, or the box to mount in B House. Not sure if it's up there yet. And once it's there, I have to distribute because we have kits floating around the halfway houses in Newark. So there's going to be on that side of Lincoln Park, it's going to be 99 Lincoln Park. On the other side, I think I'm going to put it in 49 Lincoln Park. So those are for now. If we hopefully don't need more than that, I don't know if you guys should have.
We need to have a few of them in medical. But what I was going to say is, why can't they have them in each house? Because you have a time factor in administering the medication.
That's a very good point, and we should look into that.
Then we
The
need to
whole
get more
idea is
kits.
having
Right.
this easily accessible. As an example, in the program next door, if we have a situation there, we should technically not have to order just a small hop, skip, and a jump to come across to building 6. That should be available right there. This is what we do. This is the kind of people we treat, and these are the risks that we have to be very mindful of.
Time is
would be
always
very
a
much-
factor.
Yeah.
I'm
Time is
very much in
I
favor
think-
of us having
I
at
think
least
actually
one of
it's
these things in
Is it?
all buildings within the integrity campuses.
Shouldn't everyone who's trained get a kit?
They're not your kits because you're not getting trained.
No, but I'm saying like to,
Right, I don't know, because the first trainings I was involved with, I don't know how many kits are circulating. I was going to at least, I don't know if we can get enough kits for each location, because we do have a lot of buildings here. I can try to work on it, because then I have to purchase
It's
other
really
supplies.
important. It's
Right.
really, really important.
It's
And I've
important,
gotten
look.
conflicting opinions whether we need that, so that's the other.
Who's the conflicting opinion
Well, I don't
from?
need to go into
Well,
that.
I
look,
mean-
we always look at that, but the whole point is, look, we have started, we are doing this in the areas, if I may say, at highest risk. Risk is at a continuum. The highest risk maybe this facility, 1 or 2 more, but this is something that given what we do and the kind of clients that we treat and the nature of the disease that we are treating, it would seem medically very reasonable to have this available all around. And I will speak with Bob about this.
The other thing is, if anyone, because where we're getting the kits from is NJCRI, if anyone has an interest in getting kits for, or has family members that would like to get kits, I have information that you can contact me to reach out to them, and you can walk into NJCRI and get a kit.
Yes, and there was a grant from, I'm not sure exactly who funded this, but it's right now available to family members, where you go in there, you sign your credential. This is just not exactly, you're curious, you go and get it. This is meant to be used for people who really need it, who have the disease of addiction. So you go in there, you can get this. I'm not sure if that will be renewed, but it's still ongoing, and I urge anyone who might know someone, you should just go in there and get one of those kits.
If there's 100% no risk involved, right, in this?
That's
Right,
right.
it should be a no-brainer, it should be in every one of our programs.
Okay, Wayne, your point is
Right.
well taken, and it's something that I will speak with Bob about. Just 1 or 2 questions I'm going to share with you guys that no one here actually asked, but I was asked by law enforcement in Essex County, and 1 or 2 from, I think it was in Livingston, one of the departments called me and said, now, could we use this thing in pediatrics? If we see a small kid there next to an adult who was using drugs and probably the kid is also appeared to be the same. The answer is yes. You're trying to save a child. At St. Joe's, in training, in the neonatal intensive care, we used that when females came in and they had opioid use and they were pregnant and they were high risk and they went into premature labor and they had a baby to try and stimulate the baby's breathing. Okay? Little tiny preemie in size.
Do you use the same 1 cc?
No, very different. 0.01 mics per kg per minute in an electronic med pump in the intensive care. But the whole point is the same medication was being used in a different setting, but of course this is an intensive care with fancy machines and electronic monitoring, so the identical medication, and if you see a 6-year-old next to an adult who has a substance use problem, was less than clear with their sense of discretion, and the kidney have also used it, you have no harm, you can save that child, you
So
have the
that-
potential, but you use it.
One of my reasons for asking that was because a lot of people here may not understand 1 cc, her being one of them. So if you guys, when you go up to practice, you should actually look at the vial so you can understand that what 1 cc is, because you'll see a lot of lines.
So the other
You
line you see 1, 2, 3,
Right.
4, if you guys are looking at it there.
Uh-huh.
When you actually start, the dark part of the plunger is on a number. For example, it's a number 4 right now. Wayne, could you see that there?
Yep. I think I zoomed in pretty good here.
Right. And what I basically do is I'm going to go up now, all the way, and I stop. That's number 3. That was 1 cc. This movement from there until there was 1 cc. And from 3, if I continue moving up until the number 2, once the back part of the plunger is on the number, that tells you the correct measurement, how much you actually gave. And if I went from 2 to 1, it's all finished. Okay? Point is, it's nice to know between 4 and 3 is 1 unit, and between 3 and 2 is 1 unit. If you went from 4 to 2.5, I don't care, it's not that big a deal. Nothing's gonna happen. There is only good side to this. There is no potential documented downside to this. Worst case scenario, nothing happens. Best case scenario, you save a human being. That's what we're here for.
Quick statement, and I have 3 questions. I'll just ask them back to back, and then you can address
Go ahead.
One, we'll double check. Harris and I, neither of us are aware of any Narcan unit being on the short-term unit.
Rebecca has it. I think
Okay.
she's carrying it because the other thing, don't put the Narcan on the med kits. No one put it on the med kit. It does not belong on the med kit.
Okay.
Cart, med
All right.
cart.
Or whatever.
Yeah.
My questions
Anywhere
are
their
this.
medication is.
My questions are this because, just related to like fundraising and so forth. How much do kids cost?
Okay.
Is there an expiration date on them?
Right.
And on a practical level, in dealing with a person of color, darker skin, are you still going to be able to see in the same way if they have bluish lips or bluish fingertips?
Right,
Or
okay.
is it harder, and what do you have to look at?
Good, okay, very good points. Let's take them first at a time. Price of the kits. There's a place in New York, I don't recall the name off the top of my head right now, it's someplace in upstate New York. The price of the kit is about between $35 and $45
Okay, so we're not talking big money for it. Okay.
per kit. In the case of where I work and I was actually trained and I did this program there, they purchased, I think it was 250 kits or something like that, so then you're speaking as pretty sizable sum.
Right.
But the
But
essence
you're not
of the
talking
prosecutor-
a sizable amount of money, whether for a facility or for an individual to purchase one.
Right,
Okay.
so,
All right.
by the way, for the individuals, those
We
were
get
free.
it for free.
Those were free. For an individual,
And we're
those were
debating
free
about whether or not they have money.
through that particular program.
Okay.
Institutional, you basically purchase it. The price is, let's just say, between 35 and 45 bucks
Okay.
per kit.
Okay.
And I think there might be a little slight increase if you go from the 1 milligram per cc to 2 milligram per cc. It's just a slight increase.
Okay.
And you can have 1 syringe or 2 syringes. It comes as a little tiny kit, temperature controlled, crash proof and so.
And what's the shelf life on it?
The shelf life can be several months up to 1 year,
Okay.
stored at room temperature. The way this was handled at Essex County, which was a far bigger challenge than Integrity will ever have, because you had about 20 or 22 municipalities who were involved in that training. And the way we handled it there was a database was created at the hospital center. And the folks involved in that part of it monitored. The kids came in, and let's say, for example, you Newark and you Irvington, and you both got 3 kits initially. And within a week, Newark has used 2 kits and has only 1 more, and this municipality hasn't used any. What we then do is, through that database, we transfer 1 kit from here across there. The areas of need will vary, and based on who has a higher need, we keep juggling things around. West Cornwall, we have 5 kits, and in 2.5 months, didn't use any. Guess what? We may take 2 kits from there and send them maybe to, somewhere else. Belleville.
And what about as far as the, diagnosing the symptoms, some of you call it acrocyanosis?
Right, okay, right. Now, in terms of looking for central cyanosis, or if you first it's your fingers you see first,
Right,
forget the pigmentation, the color of the skin. The nail bed is what you are looking at.
okay.
So that is very clear, irrespective of ethnicity or skin pigmentation. The tongue is also should be a beefy red. If you're looking at the lips, that may vary the skin complexion. But just looking at the hands alone, because the first place to be affected when you have a situation like this and your blood pressure drops, is your extremities as the first compromise on blood supply. You try to maintain the vital organs in your brain. And remember, this person, you find this person, if even you found them, and they were slumped over on a chair, like that. The first thing is you gently place them on the ground and you lie them flat. So when they are already laid flat, blood will flow to the brain. If they are slumped over and they become hypotensive, meaning a low blood pressure, that also is reasons, to change their mental state and also compromise them. So the first thing you do is the person is laid flat, all objects are cleared out, and then you start this whole process of giving this medication.
Thank you, Doc.
What kind of time frame are you looking at? Like, if you find somebody, all right, obviously if you walk in 5 minutes after they whatever, you got a better chance. What if it's a half hour, 40 minutes, and they've been out?
What is it? Or it is half an hour, 40 minutes, put simply, unknown time period. Once you have the right risk factors, you give it a try.
Okay.
That's what you do.
Okay.
You never say, well, this could have been, I just walked in here, who knows how long? No. The person always gets the benefit. You have to give it. That person could be what you call agonal, very, very shallow breathing, but still there, and with the potential to get things started and come back out of it. And you have no way of knowing that. That's a so-called time unknown. The person gets it.
So, because I experienced it firsthand on my unit before you had these kits available,
Right.
What happened in the case, the gentleman was in the toilet stool, and he went and shot up in the bathroom, and he was one of the student members found him in the bathroom unconscious with his pants to his ankle. So what happened in this case, it was obvious because he was faint, he was out unconscious and foaming through the mouth. Now, in that situation, someone took action very quickly, administered CPR. So with the naloxone, CPR, does that take the place of administering CPR?
Naloxone does not take the place of CPR. What it does is it actually is a part of what CPR would do to initiate breathing. You're given this drug, which will basically kickstart your breathing. This person would be lying flat. You still check the vital signs. Remember, you have very few minutes in terms of all this assessment, giving this, but 911 was also called, as you saw on slide 4 or 5. So you are doing this, you're keeping this person alive, you're buying time, but a higher level of help is hopefully on the way with paramedics. And if you have skills, by the way, in CPR, you could administer 1 or 2 person CPR if you have those skills. If not, you focus on the naloxone and trying to at least keep this person alive. And of course, lying flat on the ground.
Great.
So you said it had to be stored at room temperature? So like if you had a kit in your car or something like that, could that?
If you have a kit in your car and it's a spring or it's fall, not bad.
Okay.
Summer right now today, no way.
Okay.
Remember, inside a car, you have different kind of temperature from outside. So if outside is 95 degrees, it's going to be in the 90s with high humidity.
I'm saying that, so it
And
kills the
you have those
medication.
windows
It's not
up.
effective anymore.
The radiation inside, you go to 110 comfortably. You could fry an egg on your dashboard, which they showed last year on television. Remember, something in the Midwest? The people in the mid-90s, and forgetting the kids, or people, I don't know, in the class, they were showing that they put an egg on the dashboard and it actually was frying. You know, so if you have that egg and you're above half an hour above room temperature, you inactivate the chemicals.
Okay.
So when you're giving it, you're not giving anything. Room temperature storage. This is why these kids kept in these law enforcement vehicles in the trunk, and so it has the temperature control and how it's there unless you actually break it. I think that's why they charge that much. You know, the whole kit is all contained, it contains everything. There's a little casing, the little buffer that helps you maintain the internal temperature irrespective of the ambient temperature, and so it comes as a little kit and it's labeled Narcan, and if you want, you can even have your institution order it from these people and have your name on it also. Of course, it probably costs $5 more. I don't think those things are necessary, but if a whole company came out of this awareness and the rules changing. All right, so we're all set?
Yes.
Okay, thank you very much for your time.
Thank you.
Great.